Okay, can everyone see my screen?
Yes.
Yes, I think we can, yeah.
Okay, cool. So this is case review 10 of our series. It's an interesting one, this case as well. So hopefully we get lots of input from everybody. That would be fabulous. So in terms of your maternal history, this lady is a gravida 1 para-naught with a BMI of 21, GBS positive detected in pregnancy. Last ultrasound was at 38+5. Baby was found to be cephalic, placenta anterior high with normal fetal growth, normal fluids and Dopplers, and growth was above the 95th centile. O positive blood group, virology and scat and AD, and her admission bloods, which we'll discuss in a second. Her HB was 103, platelets 278, and white cell count was normal as well. Apologies that it's not on there. So in terms of her antenatal timeline, this lady came in at 40 weeks exactly. That was her just induction date due to the large for dates. So this was an induction of labour for large for dates over the 97th centile on the gap chart. So here is your admission CTG. Everybody happy with this? Criteria met at 28 minutes. So this is prior to prostaglandin use.
Yeah, I think we're happy. The baseline is suitable for the gestation and there's cycling acceleration, so we're happy to proceed, I think.
Beautiful. So on the 8th, so this was at 22:40, the CTG was discontinued at 23:10. 23:25 Propus was given, 10 milligrams inserted, and this lady at the time had a Bishop score of 2. CTG was stopped after 15 minutes, and the plan was to continue CTG 6 hourly, made by the registrar. Just as a little side note, I think I do say this on a very regular basis on all of our reviews. If we're putting any kind of prostaglandin into a woman, that we need to keep the baby on the monitor for 40 to 60 minutes post insertion. But one of the best things about this was that nobody put the Dawes-Redman criteria on. So hopefully the message is spreading about making sure we're not using Dawes-Redman criteria after any prostaglandin use. Okay. So moving on, we're now, sorry, this was the 8th. We're now on the 9th. At 2:30 p.m, she was examined prior to pethidine administration, and the cervix was found to be 1 centimetre dilated, so pethidine was given. At 2100, she shrom, clear liquor. 23:15, she was re-examined and found to be 3 centimetres, and due to maternal distress, was transferred over to labour ward for an epidural. At 21:45, CTG was commenced. IV antibiotics were given for GBS protocol, and then fresh bleeding was noted, approximately 40 mils at the beginning of this little trace here. And then at 2200, there was an SPR review. This client was found to be 6 centimetres dilated. It cuts off on the CTG, which is why it's not all one continuous thing. But yeah, and just as we've got all of our lovely labour ward with us, can I please ask that everybody that's putting a lady on the CTG on labour ward, make sure that they fill in the MRN and the name of the patient on our central monitoring, just purely because it means that we've got them all in a nice log, and I don't have to hand take photos of every single monitor, because you'll see that they start to get a little bit wonky the further we go along. But yeah, everybody happy with this plan? Happy with the trace?
Happy with the trace, but I didn't catch what the actual plan was.
Sorry, I didn't say it. That's probably why. Plan was just to continue and assess progress regularly.
Good plan.
Good plan. Perfect. We'll move on. So this is the larger segment of this trace. At 2200, you can see there the maternal observations were taken. Blood pressure 118/74, pulse of 90, respiration rate of 18, SATs of 97%, and temperature of 36.6. At 2207, IV Hartmann's was started. At 22:15, this lady was sat up for her epidural, and then at 22:39, test dose was given on this lady. Just as an extra thing, thank you to whoever this midwife was for making sure that we're picking up fetal heart rate throughout the entirety of our traces. I think I say this every week, but yeah, if women are being having an epidural sited, it's so important that we do make sure that the fetus is recorded on the monitor the entire time that this is being done. Okay, happy with this trace?
Yeah.
Yeah. Notable contractions were 3 in 10 at this point, 3 to 4 in 10, and they were noted on the Cerner documentation that they were strong on palpation as well. Okay. This segment here, happy with this? What are our thoughts on this one? If we're doing Dr. C bravado here, what we classifying this trace as?
She got Synto running.
No.
Got a baseline rise, and she's contracting quite a lot. Sorry, I'm dipping in and out, Cara.
That's okay.
Yeah, baseline rise, and it's less than. Let me put my glasses on. It's less than 90 seconds, isn't it, between those contractions?
Yeah.
Does she have Synto on?
No.
Oh.
No Synto. This is all her contractions.
Spontaneous.
Mm-hmm.
The contractions are stronger and going beyond the mark even. So the strength of the contractions.
So what's the obviously
six already with that.
Yeah, so I'd say we're sort of 4 or 5 at the moment. It's just worth noting though, guys, that obviously even though we rely on technology massively when it comes to interpreting our CTGs, we've very clearly here got a really good view of the contractions on the Toco monitor, but palpating those contractions is really, really important, because our hands and physically we're better at monitoring contractions than the machines are. But yeah, the midwife in this segment didn't necessarily note on her records that they could palpate resting tone. So just as a sort of top tip, if we are seeing women that are contracting sort of 4 to 5, if not more, in 10 minutes, the importance of making sure we're regularly checking the resting tone of the uterus, because yeah, we can clearly see that she's contracting well here, but we want to make sure that she is having some resting tone in between these contractions. Yeah. Well, anybody change the plan? Anybody want to do anything after this segment?
You want to slow down those contractions because it can see baby starting to distress after that. One deceleration, you've got a rise in baseline, potentially reduced variability. You've got the contractions again, resting tones, potentially to butylin.
Yeah, potentially. Okay. So terbutaline wasn't given in this case. 23:35, she was changed into the left lateral position. So our conservative measures there, seeing if the pressure on the fetus is going to improve our trace at all. 23:35, she was moved into the left lateral. And then at 23:40, she was moved into her right lateral. As you can see, the contractions have actually slowed down since she's been on her side, because previously she was in semi-recumbent. So yeah. And we've gone back to left lateral at the end of the trace. What are we thinking now?
The contractions haven't necessarily slowed down. They've become longer, stronger, and potentially coupling. You've got a continual rising baseline with decelerations. This baby's still telling you I'm not coping. If we think, why are we changing right and left lateral? What is it going to do? We're changing it for core compression. We're not changing it for fetal distress, per se. So I'd think about reevaluating that plan.
Yeah, what would you do, Saoirse?
Still give terbutaline. Still want to give terbutaline, doctor review. Because you've got a gradually here, which you know you're anticipating it's going to get a rise in baseline and wider and deeper decelerations and potentially further distress. But when was the last examination, sorry?
The last examination was at 2200 and she was 6 centimeters. So this is 2 hours. This is just the 2 hours later.
Can we?
Sorry, Cara, was there a reason why they've not given terbutaline? Was it documented?
Yeah.
Because this is what I was just about to say. So the APH that was seen at the beginning of her transfer over to labour ward, if we're assessing whether or not there's going to be an abruption, we wouldn't necessarily recommend to use terbutaline before we were going to go to theatre.
Was it because that theatre plan was imminent?
No, not necessarily. I'm not sure. What do you think, Maya?
I'm just thinking because obviously with APH you would think of micro abruptions, and then obviously if you give terbutaline you might expand that abruption. So you have to balance the fact of giving terbutaline to slow down the contractions versus making any abruption which is hidden behind the placenta go suddenly from 0 to 100. So this is what I might be thinking rather than going to theatre thing, because recent studies, they've shown that even if you give terbutaline, if you go to theatre, that's not really going to increase your risk of PPH. So going to theatre is not going to stop me from giving terbutaline. So even if you need to use terbutaline, you give it, even if you're going to theatre. I don't know if anyone else has read any recent studies, but I don't think it would really necessarily increase your risk of PPH during cesarean section. I will personally be going more with the notes of going from small abruption to massive abruption with terbutaline, because you're relaxing the uterus and view of APH, that's all.
I agree as well. I've read literature regarding sort of management of a PPH over management of resuscitation of neonate, and that's pretty much the argument with terbutaline. So it will show you if you are very quickly on the CTG if you have got an abruption. But I don't think to sort of not use a conservative measure because of the risk of bleeding. I think that's the sort of risky.
Yeah. Miss Nicol,
Anyone
did you have
else?
any? Yeah, I was gonna say, Miss Nicol, did you have anything that you wanted to?
I think that the situation in which you don't use terbutaline is if you've got a frank APH, and I wouldn't give terbutaline hoping the trace would get better. So in an acute, an acute abruption, I wouldn't give APH and wait for the trace. Sorry, I wouldn't give terbutaline and wait for the trace to improve. But I don't think there's any evidence that terbutaline makes, a small amount of bleeding worse or reveals a large amount of bleeding. If the placenta's abrupting, the placenta's abrupting. But the point about not giving terbutaline is don't then wait and sit around thinking the trace is going to get better when you've got a prolonged bradycardia. So here I think it would be okay to give it if you think it's needed.
Yeah.
I'm interested to know if these contractions palpate strongly. We can see how regular they are, but are they actually strong contractions?
They weren't reported in the documentation as being palpated. So again, just to emphasize the fact that we really need to be doing that, specifically if there are concerning features on a trace, and specifically as well if this woman is contracting very, very regularly. Yeah. So we'll move on. At 0025, SBR review again, and this lady has got 2 fully dilated. Observations, as you can see there, of BP 110 over 64, pulse of 108, so maternal heart rate rise from 88, which was an hour and a half, 2 hours ago. Respiration 17, pulse oximeters 96, and temperatures 37. So the plan made at this point at 0025 was for an hour of passive descent. Contractions again remain sort of 4 in 10. And yeah, our baseline, as you can see, has risen. What do we think now? Has this changed? Do we agree with the plan? Has this changed at all?
Can I just ask Cara what the findings were in like station, position? Was there any coding? Because that is important given to think of.
I can't remember whether it was spines or +1. Apologies.
Because if she was being given a passive descent, then it might not have been plus. There must have been degree of needing the descent.
We would routinely, despite whether or not women have got a +1 or +2 at station, we would routinely give women an hour of passive descent despite the station, just because, you know, if we can decrease that, we can increase the descent in any way, then that's always going to be beneficial to our women. So yes, but yeah, we would routinely do that anyway.
Because the fact that the baby has accelerated and the descents, we are having decelerations, although they are having good variability, we can expedite the delivery by starting the pushing and the doctors to be involved to see whether there is any progress done after the passive pushing. That's what I say.
So at the examination done at 0025, some practice pushes were done with the obstetric registrar, and she was pushing, I believe, reasonably well at the time. So the decision was made to give that full hour of passive descent just to help.
Okay.
Does anybody disagree? Would anybody want this baby to be born now? Does anybody want to leave it? Is everybody happy with the plan for passive descent for an hour? Or is anybody thinking, actually, I'd want this baby to be born now?
Tara, can I ask a question? Like Neil over here, Tara. So
Hi,
what
Neil.
are we thinking at this point? There is a definite baseline rise from 140 to 160. Also, there is a rise in the maternal pulse rate. So are we thinking this baseline rise of the baby due to hypoxia, gradually evolving hypoxia uncompensated, or is it due to chorioamnionitis? Because in
You tell
both
me.
these cases, yeah, both these cases, the management will be contrastingly different, isn't it?
Yeah.
That's what I'm trying to make out. I would like to hear from others, like what they are thinking about at this place, because there is a rise in baseline without giving terbutaline. So it's not iatrogenic. Either it's a gradually evolving hypoxia uncompensated, or it's a chorioamnionitis.
Yeah, what do we think?
I think personally it is the gradually evolving hypoxia, but compensated, not uncompensated.
Yeah, why are you saying uncompensated? Yeah, I agree with Mr. Naguib. Why are you saying uncompensated, Mia?
Because there is a real rise in baseline heart rate. Baby is trying to compensate.
I agree. I don't think this baby's compensating. Main reason being is if we think this reduced variability, fetuses don't sleep, so we can't assume this is potentially cycling. And actually, it's sort of response in the baby's not coping very well. We've seen throughout. Luckily, she's made quite good progress. Right now, we're not managing it. Potentially, what are we thinking the gases would be here? I wouldn't be continue and potentially put stress of pushing on this fetus.
I feel so sure that the uncompensated, when you say uncompensated, means few things. One is that the baby is decelerating most of the time. Two is that variability is reduced, not only rise in baseline. Here there is rise in baseline, but variability is still more than 5, in my opinion.
Yeah.
There is no much of deceleration to tell me that like I am, yes, in the beginning of the first partition of the slide, and it recovered. So for me, I don't think if I say to myself, I want to deliver this baby now because I am thinking of gases to be bad, I don't think if I do FBS or do something that this gases at the moment are bad enough to drag a baby from spines or +1. Of course, I am vigilant, but this is my opinion personally. I would sit tight and see and wait.
But how long do you think you're going to wait for? Because it's only going to get more stressful as we're in second stage. So would you be, like you said, just sit and wait? How long would you wait for this full hour?
No, it doesn't have to be full hour. I am vigilant that if any, I'm saying to myself, there is a gradually evolving hypoxia. We all agreed on that.
Yes.
We disagreed on compensated and non-compensated. In my opinion, it's compensated. So I am vigilant. I am seeing if this trace starts showing me more of chemoreceptor, that is showing me I am going to decrease my gases quickly, I will intervene. Because there is a balance here between two things, Sorge. There is a balance between, yes, baby is our priority and so on, but there is a balance between two things. One is baby, and two, a difficult instrumental that can potentially cause more trauma to the baby and more trauma to the perineum. Here, yes, it is going up, but it's not telling me I am a dire situation. I need out now. And being fully, I feel like, okay, hour of passive, but I am in and out of the room.
Okay, thank you.
Okay.
Okay. I've just checked my notes, by the way. The baby was OA and its spines, just to sort of confirm the fully dilated as well. Apologies, I didn't have that written on there. And I believe that the midwife plan and the doctor's plan may have had a slight delay and overlap. So the registrar review actually said to wait 30 minutes prior to commencing active pushing, but in the midwife documentation it was a full hour. So I don't know if that changes our thoughts whatsoever, but we'll move on. So this is our full hour of passive descent now.
Oh.
At the end of the graph, the baseline has gone up to around 170, and the variability doesn't look that good.
No.
Yeah. So I agree, Neil. The end of the trace now, there is this shallows that are telling me, oh, they are chemoreceptor. I would intervene here. Yes. This is the time I feel like, okay, this is baby is telling me, okay, I had enough, I intervene.
Okay, so we see what happens. So at 01:50, the registrar comes into the room and says, due to the changes in the CTG, and now the again increase in baseline, that instrumental delivery is necessary. So 01:56, Kiwi is put on first pull, but the Kiwi unfortunately fell off. So at 02:01, first pull with forceps. At 02:05, the head was delivered, and at 02:06, delivery of live infant.
Yes. Gases.
Gases. Who wants to guess what our gases were in this case?
7.12. Basic S3.
Yeah, same 712.
Anything? Any other comments?
7.10.
7.10. Vicinity, what would you?
I would say, looking at the end of the trace, that if I'm seeing the paired gas, so venous and arterial, I would go to 7.1 and 7.25 or something like that, or 7.05 and 7.25, like little bit of a drop at the end where there is a 4 or 5 minutes till the delivery.
Yeah.
Sorry, just before you move on, was there any signs of infection from mum throughout this labour?
No, no.
No.
So no temperature, no Rigels. There was nothing that would indicate that mum was infected, had an infection at all.
Okay, thank you.
She was on the.
What was false? Sorry.
She was on antibiotics.
She was like, yeah, so the baby has GBS, so she
Yes.
had Benpen, loading and maintenance dose, so that could have counteracted it. A maternal pulse is the second line that you can see underneath the fetal heart rate trace. So mum's pulse sat 100, between 100 and 120 pretty much for the last, well, hour. So the gases at 0206 delivery, 0207 neonatal emergency call put out. This baby had 2 rounds of inflations and 1 round of ventilation breaths before being transferred to SCBU with APGARs of 1, 6 and 10. Arterial pH was 7.01 and venous pH of 7.03.
Okay.
Looks kind of cute, doesn't it?
Yeah, exactly, yeah.
Yeah, I think we're all pretty much in agreement with that one. So the significant difference between that arterial and the venous pH is most likely to have occurred during the delivery itself.
Yeah.
Kara, can you go back a bit in the trace, please?
This one?
Yes. What was this time over here?
This was 0140, 0110.
So around 0143, the baseline has risen further and there is a loss of variability, right?
Yeah.
At that point. And when was the QE applied?
The QE was applied first at 0156. So within sort of 10 to 15 minutes.
That's right.
In the last one, Neil was saying decreased variability. I don't know whether it is because I'm seeing it on my phone. No, not this one. Yeah, I'm seeing that as more than 5. Except at the end, of course.
Yeah.
In the last 2 segments, yes, but in the first 2 segments, they are more than 5, not,
No.
I don't know.
I was referring to the last segment, Mr. Naguib.
Oh, yeah.
2 segments, I don't have any concerns. If you look at the last segment, even the last 4 minutes, if you look at that, there is
Absolutely.
definitely a difference in variability. Definitely,
agree.
that is an indication for intervention.
Agree,
At that point,
agree.
we are losing the baby.
Absolutely, Neil. You are absolutely right. Yeah. I want to just ask everybody here just a theoretical question. When you have reviewed the trace around the end of it, at the end of this segment, if she is fully, but at spines, what would you do?
Sorry, one more time.
Say again? I'm not sure whether I'm not hearing or it's cutting. Sorry. Say again.
I couldn't hear your question properly.
Oh, so Neil, my question is, let's say where the last bit of the CTG here, and she is at spines, and you feel it will be difficult instrumental in the room, what would you do?
Mr. Naguib, in her case, she's OA, and the station is at spines. So, should we think about difficult instrumental?
No, 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 no. I am saying a theoretical question.
Oh,
Is Gargi here? I think we should give her terbutaline. She has been contracting.
Yeah, so give terbutaline and
just wait for the CTG to recover. By that time, we can take her to the theater and decide what will be the best way to deliver her for a cesarean section or an instrumental.
I agree. So if you are feeling that it will be a difficult instrumental in the room, I would agree with Gargi. I would give terbutaline and move her to theater for a trial of instrumental. So I have a better lighting, a better instruments, and if I am going to get it from spines, that I might have some tears and so on. So if I am thinking globally, not only about CTG plus delivery, I would give terbutaline, move to theater for a trial. And by the time I am in theater, I can even start some Synto while the legs are up.
Yeah, I would be a bit apprehensive as well because it was a big baby on scan to begin with. Obviously, she progressed nice and quickly, but the examination would give us more information. But if it was still at spines, that would make me a bit apprehensive if it was supposed to be a very big baby to begin with.
Agree. So if I'm thinking big baby, diabetic baby, I don't know, 97th centile, la la la. Okay, fine. Give terbutaline, move to theater. I do instrumental, and I have, hopefully not, like a nice EPs, but I end up by my forceps. Fine. Usually there is a tear on the right or right of your right hand of you, so left of the patient. Usually the EPs is extended. Usually there is a 800 a liter, and you want on the other end somebody like anesthetist to manage and IV access and so on. So I mean, I would think more globally. If the situation is more a meconium and choreo and spines and OP, possibly I would, according to the difficulty of the examination and how low the head is, consider between instrumental and cesarean. But again, this is something on the day, according to the pelvis and so on.
Just one question, Mr. Nabil.
Yes, Neil.
Last 4 minutes, we all are thinking about the acute hypoxic fever going on.
Sorry, Neil, there is a double voice. Just yeah, 1 second. Yeah, okay.
So at the last 4 minutes, a couple of things. One thinking about a acute hypoxic event. I'm just
Yes.
asking your opinion. In this situation, if I'm sure it's a OA at spines or maybe +1, should we opt for QE? Because sometimes the QE takes a bit of time to deliver, or should we apply a forceps, which can be a bit more faster delivery than the QE?
For me, Neil, and this is personal and shared by maybe Ms. Tucker and Mr. Sultan from the perineum point of view. The kiwi and the ventouse in general are gentler to the perineum of the womb. From the point of view speed, this is again myself. I don't know about others. My kiwi and my ventouse will be as quick as the forceps. On the other hand, the forceps for me makes more of a hasty, like exit that causes more tears. Not like by Nagib only. It's known that forceps is more in the perineal tear than ventouse. So if it is OA +1, and my experience is that kiwi will be very quick. I don't recourse to forceps personally again except in very bad caput and in lack of complete maternal effort, where I ask her to do like trial pushes and she doesn't give me even a small budge. So my 9 out of 10 instrumental is Vontoos.
Because if we look at this slide, like ultimately the baby was delivered with forceps because there was a kiwi pop-off.
Yes, but you know, again, for me, the exit forceps is different from mid cavity forceps. I ended up in, and you might say it's my technique, and I might say, okay, I accept it. Even with the best of my best to avoid the third degree tear, when it is spines and I knew I can get it, I got it. But with massive tears. With Vontoos, um, I, I cannot say I never, but I rarely have third degree tear. And with forceps, yes, in my lifetime, I had a couple of buttonhole tear. So if I get, this is me again, if I can get with the Vontoos to get the head even to the perineum and then do a forceps, I am better with that than a forceps from the beginning. And I know I am not like, this is not universal. This is me. So I am not saying you should like everybody adopt it, but so the evidence is suggesting that double instrument increases the morbidity of the baby. But for me, if I get the baby down enough, I won with the baby, I won with the perineum. So and I can't remember something that happened to my babies after applying a forceps after Vontoos, because it is 9 out of 10 again. It is an exit forceps, like only a small lift out. So some people use manual rotation. Uh, I must admit, all the manual rotation that I did failed, and I couldn't do it. It is my technique again. I'm confessing, but my technique to like overcome the inability to do manual rotation is to rotate with a Vontoos and get it down and um, exit forceps. But again, if somebody is doing forceps in a way that I don't see if 1 in 2 or 1 in 3 or 1 in 4 third degree tear, fair enough. You know, like it's fine.
Do you apply for navel burns in direct OPs?
Yes. Yeah.
You do, right?
I do navel burns for direct OP, but again, my metal cup, which I like so much, I get the OP down, and in again many occasions it rotates with me, and in some occasion it doesn't, and it just comes as OP as it is with the metal cup, as long as I hold it nicely and my traction axis is working well. Mr. Jantan, for example, for OP uses the silastic cup. Again, I didn't see him fail so many times, and the times he fails, it is the head is on the perineum, forceps at the end. So yes, I inadvertently, when I used forceps for OP, I end up in many occasions with, even with a good episiotomy with a third degree, whether it is 3A, 3B, 3C. I didn't encounter fourth degree, but I encountered a buttonhole. So yeah.
Mr. Naguib, I'm a person who's incredibly comfortable with the manual rotation, but I've also done few OP forceps. And I've noticed, just because obviously you always reflect on your practice and you modify it, I've noticed that lateral rather than mediolateral episiotomies have given me much safer protection. I know it's much worse for the woman from pain and from bleeding, especially bleeding, because I felt that I'm always kind of getting the vaginal artery. But I don't know how with OP forceps, and I've done few, I've managed to get away with no third degree tear. However, my PPH rate was quite high. So I think it's a balance of kind of being what you're confident with and what the situation is. Neil answered your question. Like it really depends on the urgency and what you're comfortable with. The choice of instrument, if you're a person who is happy with manual rotation, then absolutely, why not? But I think it's very much operator dependent. I don't know what you think about that, Neil.
Exactly, echoing your thoughts, because like if a situation like this, and I'm
Your voice is really far away.
can you hear me now?
Yeah, better. Yeah.
So if I'm the labor ward registrar and I'm deliver a baby, I don't know. When my main concern is this baby is suffering from acute hypoxia, and I don't deliver this baby quickly, the pH is not father. At that point, maybe like it's my thinking mechanism. The only point which I'm thinking is saving time. So QE for me is like I know Mr. McGee is like QE is his favorite, but for me, sometimes it's a pop on, pop off kind of a thing which goes on. Like and by that, sometimes I feel we might lose a bit of time, which might be very valuable, like for this baby, for the events which is going on. Like if I deliver this baby quickly, I might be saving the fall of this pH any further. And it also it's in an instrument which is very much dependent, like which I feel is very much in control. Like again, it's a personal choice, as you say. It's very much in control of me. I can control, I can deliver this baby quickly. But again, by doing that, the chances of third degree failure obviously increase. But at that point, if I'm balancing the risk between hypoxic brain injury of the baby and a third degree tear in the mother, my favor somehow goes in prevention of this acute hypoxic injury.
Neil, I first commenting on Maya's operator dependent. I agree completely. All of us are different, and all of us should develop what works for us for the best of the mother and the baby. So it's not one size fits all. So definitely this, I agree with Maya. If she is happy with manual rotation, with her technique, that's brilliant. If Neil is happier with forceps, it's brilliant. But concerning your comment, Neil, about preventing hypoxia and third degree tear, I don't think the difference between a metal cup for me and a forceps is minutes. No, I slightly disagree that using a forceps will reduce the time. I don't think.
Can I
I
add something, Mr. Nagib?
Yes.
This is Bobby here. When the baseline is sitting at 140, why are we so worried about acute hypoxia?
In which case, Garg?
For this patient, I think we at least have 10 to 15 minutes. So do we need to rush that much?
So in this case, I don't think so. It started to where is it? It was 160 actually, Gargi. Which part you mean?
Like this last bit, when I'm seeing the CTG, I like definitely this baby needs delivery, but like when we're talking about minutes, like if it's 5 minutes late and it's more safe for the mother, I think kiwi is a better option than a forceps, which will cause increased risk of third degree tear or a PPA.
Yeah. So again, I would say, Gargi, whatever you are comfortable with, I am happy. As long so in my practice, I am auditing my practice personally. So if I am having extensions in the cesarean section, I started changing my technique. if I am having a bladder injury, or let's say there was comments on some cesarean section that I'm having PPH, by going into the perivesical plexus of veins, I should be not dissecting the bladder too much. If I am doing forceps and I'm having lots of third degree tear, I should be thinking of the axis of traction. If I am failing and my ventouse is popping off, sorry, most of the time I should be thinking of my way of holding the ventouse and the way I am lifting the baby while it's coming. So there is, unfortunately, obstetrics, as like I take a conclusion from Maya, from Neil, from you, obstetric is art. And the art is to know your deficiency and try to avoid it. So, for example, when I do a forceps, I look all the time on the left of the patient because I know I have done a lateral wall tear. Why? Because this is most of the time happens. Uh, does it happen on a bad scale all the time? No. It might be a graze, it might be deeper, might be whatever. But I always look, and it is without fail I look, because one or two times I was pricked. So it is all about you thinking, what is my deficiency? You are doing a hysterectomy. You know that every time you are like putting your vessels, the uterine, it is bleeding. So you do it with a sealing agent and bipolar and so on. So it is nothing, it is never in medicine. And that's why flow charts for me are for dummies. Flow chart is, yes, should be there for the guideline, but when you are doing things, you need to be like going into snake path, turning right and turning left and so on. So you need to be accommodating the decision making. But I don't think doing a forceps is quicker than a ventouse by miles. No, no, this is the only point I want to point out. It is not miles away. Thank you so much, Kara, for the lovely discussion and for the lovely CTG and for the trace. And I'm really, really thankful for all my lovely registrars for the comments, and my lovely midwives for the comments as well. Thank you so much.
Thank you, Mr. Nagir. Thanks to you.
Thank you.
Thank you, Kara, Mr. Nagib.
Thank you.
Thanks.
Bye. Thank you, Kara.
Kara?